So I just want to demonstrate why I believe the USB can be an incredibly useful adjunct with hyperangulated videolaryngoscopy. If we compare our 7.5 tracheal tube using a rigid glide right stylet, and Storz makes a similar product for its D blade, by the way. But if we insert our videolaryngoscope hyperangulated and we keep the target up top, so we preserve room for tube delivery, because this is dangerous because we then can't see what we're doing and we have trouble maneuvering because we're off screen. So you always want to, I call it 50-50, and this is a term developed by a friend of mine, George Kovach, who's from Halifax. George describes 50% of the target in the top 50% of the screen. That's ideal for this type of tube delivery device, so you can insert it, see it come into play. But notice we are still taking up a lot of space in front of the video element as we approach the target. Now, the USB, because of its two bits of metal, I can shape the distal deflection of the USB to give us a little more bend angle. We do not need much bend angle, but you just need enough to get around the hyperangulated blade, and you can see that, and I can bring this up into the target. And as I insert, if there's any resistance, a rightward twirl drops it down. By the way, I feel the tracheal rings, that's nice. And then I do my Bougie handoff, and now I have the Bougie in place, free to run a tracheal tube over. Use of this device I'm going to show is as a hyperangulated stylet with an overlying tube. I'm going to take my universal stylet Bougie. I'm giving it a slight bend shape that's going to match this, but I'm going to place it now into the tracheal tube as I would with a regular stylet, but my stylet bend angle is exaggerated. So I've stoppered this so it won't pass out. In general, when we shape the USB as a stylet, we always want that shape to be near the proximal cuff. So if we're doing a straight to cuff Macintosh blade, I straighten it like so. I want the bend angle here. If we're going to match the hyperangulated rigid stylet shape, instead of it being 25 to 30 degrees, we're aiming for a little steeper, so 35 to 40-ish. Now what happens with this device, the rigid one, this will not go down the trachea. We have to stop, pop, and drop, or we have to maneuver our hands, ratchet it out, all those things that people are familiar with using rigid stylets, and you have the potential for injury. As a hyperangulated stylet, this is way softer, so we have reduced the injury risk, but we can give it the required shape, and I'm going to just demonstrate that. And then the other phenomenon about this is we don't have to remove the stylet on placement. A rightward turn, it will allow enough unbending that we don't have to stop, pop, and drop. We don't have to worry about the stylet withdrawal until we've placed the tube fully. So I insert the tube, I've got the uvula, I come to epiglottis, I have the posterior structures, I've taken my USB, I am holding it at the depth I want to insert it, roughly 23 centimeters in this male patient. I am coming around the curve, and you can see it's got enough of an angle that I can hold it as such, that I can bring it up into the target. And as I enter, there's some resistance because I gave it enough of an upturn to get around that blade. But what I'm going to do is I'm going to turn this rightward. You can see the blue line. And now I can push it down to the proper depth, pull this out, and withdraw the USB. I'd like to demonstrate how great the preloaded technique works with the hyperangulated blade. And we're going to get the optical benefits of a small Bougie as we come down the video element. Remember, when we're using hyperangulation, we're entirely committed to the video. There is no direct view. But when we take a small device, the USB, which has an OD of 5, and we enter into the viewing window of the video element, you can see how small the space is on the screen. When we normally use a rigid stylet with an overlying tube, and we come down around the blade, you can see how big that tracheal tube, which has an OD of 10.2, how big it is on the screen. And that can impact on our ability to place the tube clearly into the larynx, especially when we have a poor view. I'm going to preload our USB onto the tracheal tube, setting the distal tip of the tracheal tube in the midsection, in the middle of the distal metallic section. I'm giving it a pinch. You do not need a lot of bend here. Historically, the glide right stylet and the rigid stylets used with hyperangulated blades have been given a pretty good bend. Even if we give it just a little, it's plenty to get around this curve as we come down. And I'm going to just demonstrate how quickly this works with the USB in preloading hyperangulation. Introduce the blade, uvula points to epiglottis edge. We've got the epiglottis edge. Here's our posterior structures. Even when the view is not great, we can just come in, enter the larynx, push this down, pop that out.